Ian, for the introduction. As Ian's mentioned, I am a research scientist at the Alzheimer Society of Canada, and I'm really excited to chat with you today about Canada's National Dementia Guidelines program, the importance of disclosing and communicating a dementia diagnosis. And if everyone could either have their smartphones or a web browser ready, that would be great, because there will be a couple of interactive questions throughout. So this project was funded by the Public Health Agency of Canada through the Dementia Strategic Fund, and our partners are the College of Family Physicians of Canada, as well as the Canadian Consensus Conference on the Diagnosis and Treatment of Dementia. So I've skipped through some of the slides from the version that you will receive just because of time, but the slides you have essentially discussed the survey that we conducted in partnership with CFPC and how the results from that survey led to the prioritization of our first guideline topic. So to jump in, our guidelines program currently has two visions. The long-term vision is to develop best practice guidelines that will improve the experiences of physicians, persons living with dementia, and care partners across the dementia continuum of care. And the more immediate term vision, which has been funded by the Public Health Agency of Canada, has been to develop evidence-based guidelines and knowledge translation and exchange tools that will improve the process of disclosing and communicating a diagnosis of dementia. Our project also has a cultural focus, so in addition to the population more broadly, we're also specifically looking to make sure that all of the materials that come out of the project are culturally competent and appropriate for Black and Chinese Canadians. So this is an extremely simplified overview of our project phases. So in phase 1, we developed the guideline for disclosing and communicating a diagnosis of dementia. And now in phase 2, we are developing practical, accessible, and culturally competent knowledge translation and exchange tools to really support the uptake of the guideline into practice. So I'll start by providing a really quick overview of the guideline development processes, the 8 final recommendations that the teams decided on, and then I'll move into the knowledge translation exchange piece a bit later on. Okay, so I won't get into this slide too much, but I wanted to provide a representation of how involved and intricate the guideline development process is. So our team at the Alzheimer Society of Canada and our partners chose to develop our guidelines using the Guidelines International Network standards. And this image demonstrates some of the processes, considerations, and teams that are involved in the guideline development. So the Guidelines International Network has partnered with McMaster to create helpful resources that will support groups in taking a rigorous approach to guideline development. So if you want to learn more about that, you can visit that email that I've popped up on the screen there. So for this project, we engaged 6 teams in the guideline development process, and these teams are continuing to be involved in the knowledge translation and exchange development as well. So each of these teams, with the exception of the expert advisory group, is made up of people living with dementia, care partners, family physicians, allied healthcare professionals, and community member experts. And our expert advisory group is primarily comprised of family physicians, specialists such as geriatricians, researchers, and knowledge translation and exchange experts. So before I jump into the 8 recommendations that we've come up with, I wanted to provide some guideline disclaimers, which we included at the beginning of our document. So everyone who contributed to the development of the guidelines really recognize and understand the challenges of the current Canadian healthcare system, including ongoing staffing shortages, leading many Canadians to go without a regular provider, difficulty accessing family health services, especially in rural, remote, and underserved areas, and an unprecedented level of burnout, absences, and turnover among staff in clinical settings throughout the country. So with this, our teams acknowledge that there will be instances where healthcare providers may not have capacity or resources to follow each of the recommendations outlined, and really want to emphasize that the guidelines were developed to encourage a culture shift towards the use of best practices to improve the disclosure experience for healthcare providers, people living with dementia, and care partners. Members of our project team also acknowledge that the word disclosure can be perceived to have negative connotations. So as such, we've recommended that the process be viewed more as an open two-way communication rather than a disclosure. We also want to acknowledge that the word patient has been used throughout the recommendations provided. However, the team recognizes that this is not how all individuals with dementia like to be identified. So for example, some people prefer to be referred to as a client or person instead. And lastly, although the guidelines are representative of the general population and the cultural considerations appear separately, it is imperative that cultural awareness and competency are implemented throughout all of the recommendations that we go through. Okay, so the recommendations were organized into 3 overarching categories. The overall approach, which included recommendations on engaging holistic approaches and instilling hope. Preparing for the initial meeting, which included recommendations about care partner presence, identifying the disclosing healthcare provider, as well as the environment and appointment structure. And lastly, the meeting content, which included recommendations on communication technique and terminology, topics to discuss, and emotional supports. So I'll quickly provide a summary of each of the recommendations, as well as just one example of a cultural consideration that was highlighted as important by the Black and Chinese community working groups. But in the actual guideline document, each recommendation is broken down into more detailed bullets, and each recommendation actually has several cultural considerations. So for recommendation 1, it is encouraged that holistic approaches to the disclosure process be engaged, such as authentic partnerships, client-centered, and relational approaches. And these approaches highlight the importance of building trusting patient-provider relationships and working collaboratively through care and shared decision-making processes. And the cultural consideration is to be mindful of heightened stigma and the impact that this may have on patient and care partner needs. So recommendation 2, the overall tone of the disclosure process should instill hope in the patient and care partner or care partners. And the cultural consideration is to recognize the connection between hope and spirituality. Recommendation 3, while it is encouraged that a care partner be present through the disclosure process, the healthcare provider should ask the patient to confirm that they would like a care partner to be present, as well as indicate who this might be. And the cultural consideration is to address stigma with care partners and challenge common misconceptions. So I'm going to jump into a little survey question. So you can either scan the QR code with your phone or go to slido.com and enter that number that you see on your screen. And the question I have for you is, who can be considered as a potential care partner when communicating a dementia diagnosis? And the options you have are family member or spouse, friend or neighbor, substitute decision maker or power of attorney, or all of the above. So I'll give everyone a minute there to fill out their answers. Okay. Oh, there's some more trickling in. All right. Yeah, so our teams felt it was important for us to define what we consider a care partner to be, because this can vary in different contexts. So because of this, we did provide a definition in the glossary section of our guideline document, outlining a variety of individuals who could take on this role, which includes but is not limited to what the options here are on the screen. So thank you everyone for responding. So let's move into recommendation 4. The healthcare provider or team or specialist who is involved in the assessment and making of the diagnosis should be the one to disclose the diagnosis to the patient or care partner. And the cultural consideration is to ensure language needs are met, including a professional interpreter if needed. For recommendation 5, if possible, the disclosure process should encompass a minimum of 2 appointments to allow sufficient time for patients, care partners to process the diagnosis and address their questions or concerns. And it is encouraged that to the best of the healthcare provider's ability, that these appointments are not rushed and that they take place in a private, quiet setting. And the cultural consideration that the patient and care partners should be able is that they should be able to define in their own language what they understand about the communication of the dementia diagnosis. Recommendation 6, the healthcare provider should first determine patient or care partner language needs and ensure a professional interpreter is present if needed. And the healthcare provider should get to know the patient and their culture to identify culturally relevant language regarding dementia. And the cultural consideration is to use culturally relevant terms, be specific, and adopt language most comfortable to the patient. So just going to pull up another quick survey question. Again, you can use the QR code or go to slido.com and enter that number. But what is an important part of communicating a diagnosis when considering the language needs of the person living with dementia and care partner? And the options are, it is recommended that the diagnosis always be provided in English. The healthcare provider should determine language needs prior to the appointment. The person living with dementia and care partner should be able to define their understanding of the diagnosis in their own language, and then both B and C. Let's give one more minute. All right, so yes, both B and C is the correct answer. So our team has recommended that the healthcare provider should determine the language needs prior to the appointment. And this is relevant to both the language, but also to accessibility needs. And also that the person living with dementia and their care partner should be able to define their understanding of the diagnosis in their own language. So recommendation 7, it is recommended that the healthcare provider explore patient and care partner understandings of dementia, provide patient-specific details, and offer language support when needed. The provision of information on etiology, type, prognosis, and available support resources are encouraged. And the cultural consideration is that culturally competent education and resources regarding the diagnosis should be provided in multiple languages to assist with acceptance and to provide support. And lastly is recommendation 8. It is encouraged that the healthcare provider use active listening, empathy, compassion, and understanding towards the patient and care partner, and should be prepared for a potentially difficult conversation. And the cultural consideration is that utilizing materials which display an individual with a similar ethnic or cultural background can help with self-identification, acceptance, and hope. So I'm going to shift into the knowledge translation and exchange piece now. And we all know that guideline documents can be long and dry and a little bit boring. So our team really wanted to find some ways to bring the guidelines to life and support their uptake into practice. And so we've created this 3-phase approach. So project teams will be working to revise existing Alzheimer's Society of Canada resources for people living with dementia and care partners. We will be creating online educational modules using the Alzheimer's Society of Canada's recently acquired learning management system. And lastly, we are developing a dementia-specific serious illness conversation toolkit. So I'll be highlighting the last piece over the next few slides, as it's currently the focus of our knowledge translation processes, and it's also currently under evaluation. So the dementia-specific serious illness conversation toolkit that we are developing will consist of a cover page outlining key information, including some instructions, a flowchart outlining the suggested conversation structure, a guiding script for communicating the diagnosis, and a complementary tool for persons living with dementia and care partners that will be developed at a later date with our working groups. We're also holding a vote with the topic guideline creation panel this Friday to rename the toolkit into something catchier and more relevant. And this name is really just a placeholder for the tool at the moment. So the flowchart that you see here, as well as the script that you'll see on the next page, have undergone phase 1 of the evaluation, where we really received feedback from project teams on the language, content, and structure of the toolkit. So these are really not up-to-date mock-ups, but we want to give you a sense of some of the additions and changes that we've been making to the original serious illness conversation tool. And we decided to add a flowchart to map out the conversation and indicate areas which may be able to be addressed in follow-up appointments rather than all in the initial appointment. So again, this is not completely up to date because we did receive quite a bit of feedback in phase 1 of the evaluation. But this gives you a sense of how we're shifting the script to be more focused on dementia disclosure. So it's really capturing the disclose phase, the engage phase, and then transitioning to future follow-up appointments. Okay, so this toolkit is now going into a clinical implementation evaluation in January. So we're recruiting disclosing practitioners who will be willing to use the adapted toolkit during their disclosure process for about 2 patients, and then provide feedback through a short survey for insight on its effectiveness. So if you or any other disclosing practitioners are willing to participate, please email me or the evaluation lead, Jensen. So I put our emails up there for you. And very exciting, the guideline will be available electronically and for PDF download within the next couple of weeks. So you can visit the Alzheimer's Society of Canada webpage or visit the page directly, which will be www.guidelines.alzheimer.ca. If you try and access that link now, it won't work because it's not live, but it should be within the next week or 2. And then keep checking back to that website because in addition to the guidelines in around spring 2024, we'll also be adding links to the online learning education, the disclosure toolkit, whatever that ends up being named, as well as other helpful resources. And lastly, the Public Health Agency of Canada is looking for healthcare providers to provide feedback about the education and training available for dementia care. Which will inform their priority setting for future work. So if you have a quick second, please consider filling out the survey linked here. And that's it from me. Thank you everyone for listening.
That's great. Thank you very much, Dr. Main. So at this point, usually we'll open it up for questions if anybody has any questions or comments. So we'll do that, and if things are popping up in the chat, I can relay them to you.
Do you want me to stop sharing or leave my screen up?
You can stop sharing now, I guess. Sure, thank you. Leslie Martins indicated the survey link has expired as of November 30th.
Ah, okay.
So I guess I would say stay tuned.
Yeah, the survey link must be from the Public Health Agency of Canada one. Is that correct? Because then I thought that it was actually December 7th, but maybe they closed the date early. But I can follow up about that if they reopen.
Okay, great. And B Post, did you want to speak to your question?
Oh, yes, I was just curious. I noted in there how you have specific guidelines or approaches with Chinese and Black individuals, and it's not mentioned about Indigenous folks. Now, there are many different people, obviously, that will have a dementia diagnosis come forth. And even like our new immigrants, you know, from the Ukraine or any of that kind of thing, I think it can be kind of hard to be specific to every single group, but yeah. I appreciate the fact that, you know, we're trying to focus on each individual and their specific needs, whether they need interpreters for language, those kinds of things. I just was curious why those two were sort of specific, and Indigenous is obviously a large community in Canada.
For sure.
That who also experienced dementia. So I just was curious. That's all.
Yeah, I really appreciate that question, and it really killed us to have to zoom in so closely on only two of the populations. In our initial application to the Public Health Agency of Canada, we actually did have Indigenous in there as well. But by the time we actually received approval for the funding, we only had a year and a half to do the project. And so we really had to narrow in the scope. And so the group decided on Chinese and Black communities because they're two of the most racialized communities in Canada. And so that's how those decisions were made, to focus on those two communities. But once this is wrapped up in March 2024, I think we're going to be spending some time bridging out this disclosure guideline to other communities, including Indigenous. And I think the Indigenous one will be quite an undertaking. So we've already started to bridge out and make connections with different Indigenous groups that might be able to support, seeing if this is relevant and applicable to them, or what we might need to adjust and add as we go. So yeah, thank you for the question.
Okay, great. And any other questions that people have about disclosure of dementia, or any other topics related to that for Dr. Main? I'm interested, Dr. Main, just to know, in your as part of your research, did you look at sort of different situations where people might, because for cultural reasons or otherwise? I remember a situation with a family that the patient was in hospital, and they had been the family had been notified that they suspected a diagnosis of dementia, but the family was of the opinion, and I understand it as a sort of a culturally based thing, that the patient should not know the diagnosis, and the family would just sort of take care of that. And I was just wondering whether these types of sort of ethical considerations came up in the research and the format of your disclosure information.
Yeah, absolutely. There was a lot of interesting conversations like that, which do vary from culture to culture. And in the Chinese community, they made it quite clear that it's usually the conversation is happening directly with the caregiver, not with the patient. And so we have advocated through the guideline that there be a little bit of a shift towards directing more of those conversations toward the patient, but at the same time having to respect and understand cultural differences and why those decisions might be in place. And so at the end of the day, in the guideline, it also says the caveat of the healthcare provider should use their best judgment for the situation that they're given, because it does vary so significantly for those reasons.
Okay, thank you.
Yeah.
And Clara Checkland, you want to go ahead?
Hi, I did the applaud hands when I meant the hand up, so sorry about that. I'm not sure this quite fits, but it's got me thinking a little bit about times where the person's been assessed, and there is a diagnosis, but it isn't. There isn't an official disclosure of the diagnosis, and then in passing, part of the rest of the healthcare team just sort of speaks about it as though the patient knows. I'm kind of wondering, how that sort of thing can be avoided. As it's not so casually disclosed, and it's not intentional. The other person, so I don't know if there's, after the testing assessments happened, if it needs to go through a disclosure, like where the patient actually gets the time to sit, if that's general practice, or if it's just written in the paperwork.
Yeah, it's really interesting. I think it depends on who the disclosing practitioner is. In the survey information that you'll receive in your slides, there were a lot of barriers to disclosure. And one is that family physicians are just uncomfortable having the conversation and don't know what to say, or don't want to jeopardize the patient-provider relationship. And so we're really hoping that providing the guidelines and including the script, and the script is really prompts to engage the person living with dementia and care partner in conversations. It's not them just spewing off information to the patient and the care partner. We're really hoping that providing the tools and the education around disclosure will help with some of those challenges, because one of the survey stats that was shocking was, I think it was 75% of family physicians knew that the patient had some sort of cognitive impairment, but there was no official diagnosis of dementia. And so it's just really trying to convert those numbers more and more to actually having that conversation. Yeah. Really good point there.
And are you working as part of your material, providing sort of messages of hope with the diagnosis and of the positives of finding out now versus later, or who knows what, but
absolutely.
Sort of thing.
Yeah, there's a whole recommendation around instilling hope. And then also in the dementia specific serious illness conversation guide, there's a whole section on goals and looking to the future, and all of the wording that we've been working with our groups for is really around the building on strengths and positivity, and trying to balance that out with also being realistic of some of the challenges that might be coming ahead.
Fantastic. Thanks for doing this work.
Yeah, of course. Thank you.
I would be interested to know if if not giving sort of a formal diagnosis, how that might impact sort of care. Is that something that you obtained in terms of information during the sort of research part of it, the background?
See why I didn't want to mute the hot tub today?
Sort of. But I think the main challenge with not receiving the diagnosis is not being able to access relevant support services, treatment options, and care management planning. Those are the real challenges with not receiving the official diagnosis. And you hear so many times that when the person living with dementia and care partner have finally received the diagnosis, it's almost like a relief, because they finally understand and know what's happening. They know what's going on, and they can start really figuring out the plans and the questions that they need to ask, and starting to adapt to that new day-to-day life. Yeah.
Yes, I've definitely seen that myself. Yeah. Does anyone else have any questions for Dr. Main? I think you're able to stay on for a little bit longer, I think. Is that right?
Yeah, that's correct.
Okay. So, but if there are no more questions, then I think what we'll do is we'll move on to the case presentation. So again, thank you very much, Dr. Main, for that presentation and the discussion questions. So the case presenter today is going to be Jessica Phillips-Hunt, and I'll ask her to go ahead now and put up her presentation.